And we will be um, starting people on Tirzepatide. Everybody on the study will get Tirzepatide, but there's a randomization for two groups. Group one will begin the therapy immediately, and group two will begin 6 months later. And our primary endpoint is comparison of adiposity, weight, and fat biopsy parameters at baseline from baseline uh, to 6 months between group one and group two, because by that time group two is not on any therapy. Then group two will also begin, and then we also have full assessments at the end of the year. And at that point in that analysis, everybody gets their own before and after results compared. So that's sort of like the design. We are also collecting information about diabetes, triglycerides, and liver-related endpoints, and lots of different biomarkers. So our and the way that we started to do this was noticing that patients whom we started on tirzepatide for inadequate control coming in with remarkable improvement. So then we said, okay, we really need to study this systematically so that we collect the evidence base, and that way insurance companies don't give us trouble for starting people, because we were having a lot of difficulties when people when we wrote prescriptions and people were saying you need to have two peer-reviewed publications. So insurance companies are coming up with all sorts of barriers. So then we said, okay, let's just publish whatever data that we have, number one. And then number two, let's also write a grant and see if we can do a systematic study. Now, when we do a systematic study, we have to create some criteria. So, as we've discussed multiple times in these lunch and learns, um, when there's a study ongoing, the primary focus is really contributing to generalizable knowledge and to help get the most accurate scientific information so that the evidence base is formed for informing future clinical practice. One of the criteria that we have in the study is that people either shouldn't be previously treated with tirzepatide, or if they were, that they're willing to come off of it for about 6 months. So we understand that's a hardship for some individuals are already being treated. And if your focus is on fully yourself and your self-care, we understand that that's too much sacrifice. But we're also aware that there are quite a few patients who either haven't started yet or who don't qualify through their insurance. And those are the individuals that we're hoping would participate in this study. We do provide tirzepatide from the study, so you will not be charged for any medication and any of the testing that we will do, starting with screening. So you will have to come to Michigan for the screening, then baseline medications start. Then we do a lot of virtual care um, for people who are not local. For people who are relatively local and who would like to travel, we also see them in person. So both options. So at 6 months and at 12 months is when we need you present at the site. So that's the study that we have sort of proposed. There are some other like background research that will be happening or overlaid One of it is sort of like trying to develop non-invasive biomarkers that help us determine insulin sensitivity or validation of previous biomarkers. So, from a single blood draw, and for example, your continuous glucose monitors, could we come up with your insulin sensitivity? Uh, it, that's another sort of like a research that's overlaid. We have endpoints about side effects and tolerability, and then we also have endpoints about how patients feel, mood, pain, and quality of life measurements, in addition to hunger, things that we know tirzepatide impacts sort of globally. Um, so that's sort of the background. We will be collecting a lot of information when people come. We will be in touch a lot throughout the study. So there's some, what we call participant burden. And we try to do some compensation for the burden that we provide. But as you know, there are rules about study participation compensation. They cannot be enticing. There are limits to what can be offered. So we're sort of like staying within the guidelines of a therapeutic study where the participants are expected to also have benefit, direct benefit from their participation. So in terms of people who've had pancreatitis before, there's a question on the chat. We will make individualized decisions, so that's not an absolute contraindication. Our clinical experience does come from patients who've had pancreatitis before, and we do believe that by improving your metabolic outcomes, we actually mitigate the risk of future pancreatitis. So we haven't necessarily seen terrible pancreatitis. What we have seen, however, is when people, I'm sure you remember the time that Monjaro and Zepbound was on shortage. There's been this huge demand by everyone, right? These medications also do cause weight loss, right? So a lot of people want them for cosmetic reasons also. And with that demand, there was some shortage. So a few patients who were started on therapy had to just, without any notice, had to just stop because they just couldn't have any access and there was nowhere that we could find the medication. If people come off suddenly, that may trigger an episode of pancreatitis. Basically, if your numbers are rebounding relatively rapidly, that's what puts you at risk for pancreatitis. So, I mean, in this study, we have our drug supply, right? So hopefully there will not be any interruption of therapy for anybody. And then once the study is done, we will do everything we can to help people obtain tirzepatide by providing all sorts of documents to their insurance companies about any benefit that happens on the study. So that's a commitment from us to the participants. But of course, there's no guarantees that we are in a position to provide therapy indefinitely, but we will be very committed to help people get this medication. And our hope is that the evidence base will be there. Now, another paper that we just are submitting right now is our early observations of leptin and Zepbound. Sorry, I shouldn't say Zepbound. Tirzepatide together. So leptin and tirzepatide combinations, or let me even say incretin therapy, either tirzepatide or semaglutide combinations together with leptin. And I'm happy to say that these early observations that just happened in the context of us continuing leptin therapy in patients or uh, people with generalized lipodystrophy who have been on leptin for their clinical care. But then we felt like, okay, they could use additional help. And then we've added tirzepatide clinically, and we've seen an incredible response in those individuals, making us think that the two drugs together are helping, are either working very well together or they're synergizing each other's effects. So that's another route that we hope our research will continue. So, as we're launching our study, another thing that we will be working in the background is, for the individuals who are finishing the 12 months on therapy, whether we can then introduce leptin or placebo or a leptin-based therapy or placebo, sort of like in the second year. But that's not a done deal yet. So we're doing everything we can to have that study sort of ready to be there for our individuals completing 12 months of therapy. Um, so um, I mean, I think those are like the gist of the study. And I'm happy to answer questions. I think um, I got the pancreatitis question from Gail answered. Um, um, the next
Before you answer the questions, Dr. Oral, can we go over, because I see the question on the chat, can we go over about the inclusion-exclusion criteria a little bit more? Because people ask if you have any specific metabolic inclusion and exclusion criteria.
So at the moment, the current criteria are for people with a diagnosis of familial partial lipodystrophy and then a hemoglobin A1C over 5.7, which is the limit of prediabetes at 5.7 and above. And then that's it, I think. Those are like the only. So the triglycerides elevated is also something, if it is there, we will follow those individuals will contribute to a triglyceride endpoint as well, but it's not a requirement.
So familial partial lipodystrophy, all types?
All types, yes.
Perfect.
Yeah, and if people
Any
have acquired partial lipodystrophy in this study, we're not looking at, and then for if it's a definite that they're acquired partial, this study is not for them. Most of the time, those patients don't have as severe metabolic complications, but if they do have severe metabolic complications, we're happy to see them clinically and see what we could do.
So generalized lipodystrophy, this study is not currently looking at generalized lipodystrophy.
This study is currently not looking at generalized lipodystrophy, but for the most part, if people do have a generalized lipodystrophy and diabetes together, we are seeing that if they wanted or needed to be on additional therapies, that we're able to get them approved.
Oh, can we go over maybe the screening process for the patients? So do they need to come to see you guys in order to sign the consent form, or can they do it online? And then what kind of procedures do they need to do on the screening period before they get the medication?
So we do want people to come in on site for screening, and we will be obtaining their blood work, and we will be doing some imaging studies during screening, and then we do have like a run-in period, so we do want them to be like certain medications, we want them to be relatively standard during this run-in period. So we're going to make some changes to the background therapy to try to get them a little bit more standardized. And then we will bring them back for um, for the baseline assessment. And during the baseline assessment, the things that we have done at screening, such as like liver imaging, it will be repeated. The blood work will be repeated, and then people have the option of participating in a fat biopsy study. So whole body composition, MRIs, blood work, and then optional fat biopsies. When they come for baseline. At the baseline, we start them on the first dose of therapy, and then we will be talking to people in that third week. Once they finish the third week, we will start talking to them, and then if they're tolerating and ready to move up to the next dose, we will be shipping the next dose to them. If they're having some problems, and we feel like the first dose needs to be continued, or we're seeing a lot of weight loss, anything that we're worried about, we may just renew their dose. So if people are tolerating, we'll move them up. But if people are not tolerating, and there are reasons that we need to go slow, we will just go slower. And the goal is to get them to maximum dose if they can tolerate it by 6 months. But some people we know that not everybody is able to tolerate. So there's some leeway from a mutual discussion about their tolerability.
So
Can you
will they all?
just
Oh, go
really
ahead.
quickly, while we're talking about dosage, what is the maximum dose?
The maximum dose of tirzepatide is 15 milligrams, 1.5.
So if you're seeing response for folks, are you still looking to move up just for the trial for information?
Yes. If people are tolerating, we do want to get them to maximum dose by 6 months. But if there are tolerance issues, too much weight loss, abdominal pain, etc., then we will scale down. And that's like throughout the entire trial, so there's a lot of leeway on how we make those decisions, like and set criteria.
And they are all going to start at 2.5 milligrams, right?
Yes, everyone will start at 2.5 milligrams and then we'll move up.
If we have patients on tirzepatide right now and they want to stop taking it, they need a washout time of 6 months, correct?
Yes. And
Yeah,
then
so
if people are wanting to do it, I encourage those individuals to get in touch with me, because we might be able to help them do transitions, or the weaning off, if there's desire to participate. So we don't want, clearly we don't want that to be done lightly, and don't do it alone,
yeah.
so that's what please, like, just for the sake of participating in this trial, please do not come off. If you're on therapy, just for the sake of the trial, don't stop on your own, because that's the last thing that we want. Like, we don't want anybody hurt, from this process. Okay, so
Yeah.
there are like lots of questions in the chat. Are there anything else that you want, Sharon?
No, we can go to the chat. One question is, will your research eventually lead to insurance companies approving tirzepatide for FPLD?
That's our hope, and we will work very widely. If the trial results are positive, obviously the results will be published as quickly as we can, and we hope that will provide the evidence base for insurances to pick it up for individuals with diagnoses. It is possible that, if our results are really good, that the manufacturers could sort of file with the FDA, but they they may not care as much, since they're selling their drugs really well. So we'll just see, what happens on the manufacturer side. But from our side, we will do everything we can to talk to insurance companies if need be.
Mhm. And from the foundation side, we'll work with Dr. Oral and team. If they're standardized templates and letters, we'll work on our end to support that process at that time. Yeah.
So the hemoglobin A1C criteria is currently 5.7 and over. However, like this is how it is at the moment. If we feel like we're just not able to find enough patients, to do the study, and we're going to look to enroll 32 individuals, then we may revisit and make some changes on the criteria. However, we do want to show multiple layers of benefit. So with that in mind, having a relatively abnormal number at baseline, so there is room for improvement once you have an abnormal. If you start with a really normal number, then it just doesn't want to improve as much, right? So, and the stats get difficult. So to the extent that's possible, we don't want to make too many changes after the trial is launched to enrollment criteria. But this is it's ambitious to say that we're going to find 32 individuals who'll be eligible and who'll want to go through with the burden of the study. I'm optimistic that we can do it, but let's just see how it will go. Right. And, let's also hope that, there is no pandemics or anything that interfere with our trials, right? Like the world has been through a few different crises in the last decade. So it's so hard to make plans, you may hope for one thing and then um, something completely unexpected may arise. Hopefully, life will stay relatively stable and we will be able to do our trial as planned. Let's see. Have we covered some of these? So the hemoglobin A1C criteria, acquired lipodystrophy. Okay, so and then
Yeah, I don't see any question, but Nicholas, right now, patients that are on Tirzepatide cannot enter the study. So you need to be at least 6 months off Tirzepatide in order to get into the study. Okay, so this is something you need to think about.
yeah.
And just
then
I want to reiterate, since Nicholas was joined late, if you decide that's something you want to do, work with Dr. Oral. Don't just stop.
Or your doctor. I mean, like we do want to do this very, very responsibly. So we want to collaborate with you and with your physician locally and have a very safe plan of transition, right? So we do not take this lightly. Like please do not come off on your own. Please. I mean, I can't stress that enough. Please don't do that.
Dr. Oral, can you so many folks ask us, what's it like to participate in a clinical trial at University of Michigan? Can you give us just some high level, just the basics? Like, I'll start. You would fly often to Detroit and then commute to Ann Arbor, which is a pretty short commute. And then would folks stay at a hotel? Would they go to the hospital? Do they stay overnight? Can you talk about what that might look like for this trial?
For this trial, it will be a hotel stay. So no overnight stay at the hospital. So everything is done as an outpatient. And because this is an NIH-funded study, we do want to cover your hotel bills. But the way that the government rules are we can't do it before you get here. So we would have to reimburse you after the money is spent, unfortunately, because of the way the government has set rules. Um, we are looking to see if we could do direct short code billing to some of the hotels, but we haven't gotten approval about that yet. So we're looking to see if we can remove that burden that people would put stuff on their own credit cards. And then because the reimbursement is, the rate of reimbursement isn't fast enough. So we will be, um, we're doing everything we can to reduce that burden, but we'll so
And
basically you're staying at a hotel, you're coming in the mornings, you know, typically fasting, and then while you're here, we're doing um, you're meeting with the study team first thing in the morning. You will have to sign consent on site, but we will be sending you the consent forms to review prior. There will be more than plenty of time to answer your questions before you sign the consent. And then there will be a separate consent whether or not you wish to participate in some of the overlaid studies and the fat biopsy. And then you do the screening studies. As mentioned, for the screening, there's nothing invasive going on. The worst is some imaging. Other than that, it's not that invasive at the time of screening. And then we will we will look over your background medications, make plans, and then make sure that those plans work. And then we will be in virtual contact, making sure that you're staying within safety guidelines. And then when you come back, you're actually randomized. So and based on the randomization, which this is so open label, so both of us will know which group you're assigned, but we will find out on the morning of assignment. And based off of that, you either stay with whatever therapy that you're on, but complete all the baseline assessments. And then we still follow you every month virtually for the first 6 months. And then if you're assigned to the drug group, you do get your first month's dose given to you, and then we send you back. So
yeah,
what?
before you, I think there's some questions about which imaging that I'll pass to you in a second. I want to share from our perspective at Lipodystrophy United that we know and absolutely understand that participating in a clinical trial on a placebo feels like a real sacrifice, and it is a real sacrifice. And also, we can't stress enough the importance of having that information when the FDA is reviewing, or you know, when any other stakeholders, pharmaceutical companies, the FDA, insurance companies, when they're looking at requests for approval or reimbursement, they really want to ensure that a treatment works. And unfortunately, anecdotal evidence, like, I mean, I can talk about how Tirzepatide makes me feel. That's not enough, right? They really need to see that there's a difference between taking it or not taking it. And so we can't stress enough how much we understand that's a sacrifice and how much it's really giving knowledge to the community by your willingness to do that. And yeah, it's incredible and wonderful. 6 months is a relatively short period of time to know that you will absolutely then receive treatment. So if you're thinking about this study and feeling a little uncomfortable about that, we want to acknowledge that ourselves and also express extreme gratitude for anyone who's willing to do that, and know that you will get the treatment.
Exactly my words, you know, like I don't think I need to repeat what you said so eloquently. It's an incredible sacrifice to participate in a clinical trial. Um, but it's such a vital um, thing for progress. And it's not just the FDA, it's also the insurance companies,
Right.
or other regulatory bodies and hurdles. So having the proof, that's needed is incredibly helpful.
Can you talk about which scans exactly, which imaging you'll be doing for this trial?
So we are doing MRI of the liver and also a DEXA scan. So those are like the two forms of imaging that will be done.
And in this, those are covered by the study,
Those are covered by the study.
and individuals get their results. They get to
Yes,
see those results,
yes,
correct?
yes,
Yeah.
for
So
sure.
that's a real give back. And that's true for anyone who starts on placebo or not. You actually will be receiving just information and benefit and knowledge.
Right. And then the other things, like, so for example, if you come into the study but you haven't had genetic testing done before, we will work to get your genetic testing, and then we will try to get that report back to you, as soon as we receive it. So there will be things that will come back to you as medical reports and medical information. So that's one benefit that the participants get.
And they get your team and you. I mean, you will be in touch with them. They can ask questions. This is something that not everybody can have, like a full team that specifically is looking on them. And from my experience, I know that patients, and it doesn't matter if they are on the treatment or placebo, they do much better once they are in a clinical study and they have a full team on them. I mean, it makes a change in the treatment or even in the way you treat yourself. So this is a huge plus for patients.
Right.
I agree. I really want to, Dr. Oral won't say this about herself, and we can say this, that we understand the travel is a burden. We understand that it's really scary. I've been a leader of this community in a long time, and I don't like to go do tests. It's really hard for me too.
Yeah.
But I do also know that being seen by a professional who isn't telling me that this is my fault, who is acknowledging that I have gone so many years with this struggle, that alone is a real gift. And so it's not our job to we're not trying to make you do this by any means, but we really do want to emphasize that we recognize we're in this with you, and we know how hard it is to go to a doctor who doesn't understand what's happening. And to be able to see a professional who says, yes, this is what's happened to you your whole life. This is not your fault. These are some options. It's worth the scary part of the travel and the hotel. I mean, we recognize the burden, and we also really want to share our belief that this is a real step forward for anyone who gets to participate in something like this.
And for this community, you're in the right place. If you have any questions, like, we'll answer them. We'll send them to Dr. Oral, or you can email her. Her email's in the chat. There's a whole community here for you. So just reach out.
And then again, I mean, I always also say, if this is not the right time for you to participate in a clinical trial, this burden is too much, that doesn't mean we're less committed to you. We will still, we could still see you clinically or provide information if you can't travel. Our commitment doesn't change. We understand, we're making this ask, and the recruitment is open. The announcements are out there, but again, please, don't view this messaging as like you have to participate. Okay, like there will not be any reduction of our commitment, for people who are not able to participate. That we understand a lot. So And if you're already on therapy, please do not stop it, just for the sake of participating in the study without discussing with us. And we will then make plans. I mean, I want to keep repeating that because I don't want
Yes.
to get the wrong message out here. Okay. One thing I forgot to mention, another study, another piece um, that will happen is we will have you see an eye doctor when you come for either the screening or the baseline assessment. And then you will be seen again at 6 months and 12 months. And the only reason for that is that there's been some literature. The only negative thing that had come out of all the GLP-1 effects so far, and that's more with semaglutide, is sort of either worsening of diabetic retinopathy or some early ischemic changes in the retina as well. But out of abundance of precaution, we are making sure that we capture what's going on in the back of your eye before we start you, and then we will monitor it twice more during the study. So you will also get those reports. Okay. So I forgot to mention that, I think. Okay. I should have
Can you
prepared
talk?
slides, but sorry,
No,
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 we,
this is
we
perfect.
can follow up also with information on
yeah.
Lipodystrophy United. We'll work with Dr. Oral's team to put together an overview that's available to you and make sure that that's approved by her team.
Right.
Can you talk about the drug itself, Tirzepatide, and what patient can expect when taking it? So side effects, what measurements they will reduce, the drug will reduce?
Sure. So tirzepatide is a drug that's synthetic. It's manufactured, so it's not a naturally occurring molecule, but it's been shown to activate receptors of two hormones made by the gut. One of them is GLP-1 and the other one is GIP. So these two hormones that the gut makes are like the yin yang of like our gut's motility and how the gut signals back to the brain about its capacity. So, and these signals not only talk to the brain, but they also talk to the pancreas to tell the pancreas to get ready for food that's about to come. They also signal to the liver to sort of get ready for storage of food that's to come. And then the biggest signal is back to the brain that there's enough space occupied in the gut. So when all of these signals, and it's an acute, both of these signals are relatively acute, meaning they're immediate. We eat the food, and then the body makes these hormones relatively quickly, and they're supposed to be there for relatively short periods of time. So the body actually has enzymes to degrade these two hormones pretty quickly. And as these signals were discovered, the drug companies said, okay, could we give these signals from outside? And then they also said, okay, could we make the body's own signals last longer? So the enzyme that's degraded has been inhibited as diabetes drugs, so we call them the DPP4 enzyme inhibitors. And those are the drugs that you know as Januvia and Tradjenta and a few others, and they may be marketed with other names in Europe. These are pills. But what research has shown that giving the signals directly in the form of peptides, synthetically made peptides, actually was far more potent in bringing the blood sugars down, which was the first target. And then it was observed that people were also losing weight, right? And then it was also observed that if we introduce these signals relatively slowly and slowly built up the signal, that people tolerated them better, and we got more pharmacological effects. So we're basically now really using them as drugs and not physiological signals. So we're trying to benefit from them above and beyond physiology. Um, we're looking at what we call pharmacological effects. So the side effects that people experience is fullness, and bloating, and then the gut mobility is slowed down, and that might cause GERD, gastroesophageal reflux, or heartburn. Um, so those are like the immediate adverse events because the gut moves a little bit slower up front. Um, it's still able to sense that it's moving relatively slow. So then it's sometimes it's like the lower gut is trying to move things along by sending other signals. And then that might cause a little bit of unpredictable bowel movements, or you may experience constipation and diarrhea in an alternating fashion. And then the drugs are administered once a week. Sometimes people tell me that they're experiencing constipation in the early part of the week, and then they have more bowel movements and a little bit more unpredictability and diarrhea later on. And sometimes when people stay on the drugs long enough, it changes. The pattern changes to almost more diarrhea up front and then more constipation in the middle of the week, followed by diarrhea again. So there is some real possibility for experiencing some discomfort in your abdomen, and the feeling of fullness. Okay.
Knowing that, will you recommend folks increase fiber? Will you have them add psyllium? Will you add a protease inhibitor? Is that what it's that like Tums, or are there any things
H2
you can
blockers and
recommend?
things like that. Yeah. So in terms of what we will be doing at the beginning, we will give you a lot of dietary guidance about how to start eating, once you start these drugs. And then with those modifications, we're hoping that we could mitigate a lot of the side effects people experience. But if people start to tell us about constipation or bowel movement abnormalities, then we will add pharmacology for that.
Okay.
So that's sort of like our our strategy, and a lot of the side effects could be mitigated by that discomfort feeling could be mitigated by really adjusting food intake at the beginning. So one advice that we will give would be to really get your portion size to half, starting with eating half of your normal portion size. And then, we will, of course, go over all the healthy eating guidelines. So, I mean, we will be holding your hands a lot once we introduce the medication to make sure that you're not having difficult a lot of difficulty with it. So that's the immediate side effects. Um, what's noted in the package insert are like the relatively low risk of pancreatitis, but our population comes in with relatively abnormal pancreatitis, or the incidence of having had pancreatitis is higher. So of course we will be very careful about those kinds of symptoms that people may experience. And then in terms of the really low risk and more theoretical risk of eye disease or worsening eye events, we are making sure that we get a picture of your retina prior, and then we will be monitoring that throughout the study. If you're on insulin, we will be lowering your insulin once you're starting, so we have we have a definitive protocol that we'll be following for that. So we do want to prevent hypoglycemic episodes. So that's another precaution we will be taking.
We have 5 more minutes. There are a few more questions in the chat. Is there a danger of losing what little adipose is in the limbs along with the weight loss in the trunk? And if so, what are the dangers?
So your legs may end up looking smaller, okay? But remember that in familial partial lipodystrophy, there is sort of um, the muscles look bigger than normal, right, to begin with. And it's because there is fat in between the muscle fibers, and that fat is protected and relatively hypertrophied in familial partial lipodystrophy, at least in lamin related FPLD2, which is the most common form of the disease. Like more than 75% of individuals with familial partial lipodystrophy who link to a single gene have that. So we believe, and hopefully we'll be able to prove this, is that we'll be seeing that particular compartment of lipid, not necessarily your muscle fibers, but the lipid that's in between muscle fibers and inside your muscle cells is what's going to go away. But that would mean that your legs may look smaller. So there's that cosmetic concern, that, there will still be a little bit of asymmetry, right, in the body. We're not really fixing the underlying defect. But I do believe, based on what I've observed so far, and hopefully our data will prove that most of the lipid loss will be from the upper body where there's a lot to lose. So that's
You all are beautiful no matter what.
yes. Yes. So, I mean, I'm just basically saying there's more lipid to be lost from the upper body. Not that, this is,
Right. Yeah.
I mean, people are beautiful. Our patients are beautiful no matter what. But we are, I mean, what I'm trying to say is that there is more lipid to be lost from the upper body versus the lower body, and we are hypothesizing that it's the upper body lipid loss that will predominate once we have all the data together.
Yeah. Is the research so far indicating that FPLD patients will be on a microdose or lower dose for a lifetime, even after reaching a goal weight?
I mean, this is true for almost everybody, not specifically for familial partial lipodystrophy or other patients with lipodystrophy. That any benefit that you get with these drugs, are there while you're taking them. And then once you stop them, it takes a while for everything to wash off. The drug washes off of your system, let's say in 2 weeks, right? However, the biological changes that the drug cause, it takes 6 to 8 weeks, perhaps 12 weeks for some of the effects to completely reverse. So after that time period, whatever condition that existed prior to the drug coming in is sort of there again. And where there's a lot of data is the weight loss that happens on these drugs, starts to be rebounded, starting after 12 weeks if discontinuing the drug. So we're looking at these as chronic therapy. And the dose to be adjusted, of course, yeah, to the desired where we want to be for both, all defects, blood sugars, weight, liver fat, and triglycerides, right? For all of those.
Yep. Any tips for hair loss?
So again, in our dietary guidance, we will be talking about total protein intake and how to increase protein intake and where to get those sources. So again, we're hoping that the hair loss will be mitigated by keeping protein intake relatively at a higher level, or not, like prioritizing protein intake and fluids. In our nutrition regimen while doing that. If we lose a lot of weight, no matter what we have, there will be some hair loss because the body goes into a turnover state, but then that comes back. So typically that's been my clinical experience so far. For whatever reason I prescribe these drugs, that the people who had the greatest weight loss have noted more hair loss, but almost everybody, after they've been on it long enough and totally acclimated and is on the chronic phase of therapy, they all come back and are happy with their hair. So once we get people stabilized, that doesn't seem to be as big of a concern.
And final question, if you are on a PPI with existing GI issues, how would that be affected?
So we would continue it. We will not reduce your dose or anything. We may need to increase the dose, but that's, if we have a lot of symptoms, we will deal with it. Again, by adjusting portion sizes and the timing of meals with relationship to sleep times, we are able to mitigate a lot of the side effects so far.
And again, I think that we're speaking in what we've seen generally. It is possible that folks would actually have a reduction in heartburn or GERD versus an increase, right?
Yes, because the visceral fat might decrease, the liver fat is going to decrease, and that might, like any push that you have from the abdomen into sort of contributing to the esophagus being stressed, there's less of that. Even in individuals with obesity, when we give these drugs and they lose weight, yes, initially there may be just a little bit worsening of GERD, but once the food intake is adjusted and people acclimate for chronic phase of therapy, almost everyone is happier, even with GERD endpoints.
How's everyone feeling? That was a lot of information. If you have any questions, feel free to follow up with any of us. We are always here to answer questions.
And I didn't even tell you about our other studies, but I think this was good, to be able to just talk about this today. I can come back in a few months and tell you about other things, and I'll create handouts and slides, so that you can look at that.
And if you want to watch this back or want to watch any of our other lectures that we've done, I just popped the link in the chat. So this was recorded, and we will be putting it available for anyone to rewatch or watch for the first time.
Dr. Oral, as always, you work more hours than most, and for you to give us an extra hour on a Saturday is a real gift.
Yeah.
The same goes to everyone in this community. We know your energy and time is limited, and your work and participation in our community is so incredibly valuable. So thanks to everyone, and thanks to Sharon and Kate for guiding our day-to-day information. We're really all in this together, and I think we're getting stronger every
day. Every month, every day.
Yeah, I'm totally grateful for the opportunity to come and talk to you. These are energizing for me. So I don't consider it as work. I am very happy to see everyone who's here. Really delighted to see the energy and interest, and really seeing Lipodystrophy United become so strong and powerful. Has been like a big gift for me. So,
Our collaboration is powerful. That's what's powerful.
thank you so much, for all you do and for all the community volunteers,
And
for
if you
me.
want to volunteer, reach out to me.
Yeah.
Thanks,
We
everyone.
love you all. Bye.
Thank you.